the invisible enemy, a constant threat in our hospitals. Hospitals are places of healing, however, they can also harbor hidden dangers. Healthcare-associated infections, or HAIs, are infections patients acquire while receiving treatment. These infections can be deadly, prolong hospital stays, and increase healthcare costs. We must be vigilant in the fight against HAIs. Surveillance is our strongest weapon. By tracking and monitoring these infections, we can identify trends, pinpoint problem areas, and implement life-saving interventions. Every hospital must prioritize HAI surveillance. It is a fundamental aspect of patient safety and a testament to our commitment to providing the best possible care. We must remain dedicated to this critical mission as lives depend on it. Guardians of health, the crucial role of surveillance. Surveillance is the cornerstone of HAI prevention. It involves systematic data collection and analysis. We track the occurrence of specific infections within the hospital, which allows us to understand the scope of the problem. Effective surveillance requires a multidisciplinary approach. Doctors, nurses, epidemiologists, and infection control professionals must collaborate. Together, they gather data, analyze trends, and develop targeted interventions. Surveillance is not merely about counting cases, it's about understanding the why behind the numbers. Why are certain infections increasing? Are there common risk factors? By asking these critical questions, we can develop strategies to combat HAIs. Surveillance empowers us to create safer healthcare environments for all. Unmasking the culprits, common types of HAIs. HAIs can manifest in different forms, and each type poses unique challenges. Understanding these distinctions is crucial for effective prevention. Catheter-associated urinary tract infections, or CORTIs, are among the most common HAIs. They occur when bacteria enter the urinary tract through a catheter. Central line-associated bloodstream infections, or CLABSIS, are serious infections that develop when bacteria enter the bloodstream through a central line. Ventilator-associated pneumonia, or VAP, affects patients on ventilators and occurs when bacteria infect the lungs. Surgical site infections, or SSIs, can develop after any surgical procedure and happen when bacteria contaminate the incision site. These are just a few examples of the many HAIs we encounter. Each presents a unique challenge. Continued vigilance and targeted interventions are crucial in the fight against these infections. Battlegrounds, high-risk areas under surveillance. Certain areas within hospitals demand heightened surveillance. These battlegrounds are breeding grounds for HAIs. Intensive care units, or ICUs, house critically ill patients who are more susceptible to infections. Surgical wards where procedures compromise skin integrity are also high risk. Neonatal intensive care units, or NICUs, require specialized surveillance because newborns have immature immune systems, making them highly vulnerable. Burn units pose unique challenges as burn patients are highly susceptible to infections. By focusing on these high-risk areas, we can allocate resources strategically and implement targeted interventions to protect our most vulnerable patients. Section 5. Keeping watch, data collection. Our weapon against HAIs. Data collection is the bedrock of effective HAI surveillance. We must gather accurate and comprehensive information. This data will shape our understanding of infection trends. We use standardized surveillance definitions to ensure consistency in data collection. This allows for accurate comparisons across time and different hospital units. We track various data points, including the type of infection, the date of onset, and the patient's risk factors. We also document the microorganisms responsible for the infection. This helps us identify patterns in antibiotic resistance. Meticulous data collection is essential for effective surveillance. It allows us to track progress, identify outbreaks, and implement timely interventions. Section 6. Measuring the enemy, calculating infection rates. Raw data alone doesn't paint a complete picture. We need to calculate infection rates. This allows us to compare data over time and across different units. we use standardized formulas to calculate infection rates. These formulas account for factors like the number of patients at risk and the length of their hospital stay. For example, the CORTI rate is calculated as the number of CORTIs divided by the number of catheter days. A catheter day represents 1 day a patient had a urinary catheter in place. Calculating infection rates allows us to understand the true burden of HAIs. It helps us identify trends and measure the effectiveness of our interventions. Data-driven decision-making is essential in the fight against HAIs. Section 7. Benchmarking, comparing ourselves to improve outcomes. Benchmarking is a crucial aspect of HAI surveillance. It involves comparing our infection rates to external standards. This allows us to gauge our performance and identify areas for improvement. We can benchmark against national databases. These databases collect data from hospitals across the country. We can also participate in collaborative initiatives. These initiatives allow us to share best practices and learn from our peers. Benchmarking helps us understand where we stand. Are our infection rates higher or lower than the national average? Are there specific areas where we need to improve? By comparing ourselves to others, we gain valuable insights. We can identify best practices and implement changes to enhance patient safety. Section 8. Declaring war interventions based on data insights. Data analysis is only valuable if it leads to action. We must use our findings to develop targeted interventions. These interventions are designed to reduce the incidence of HAIs. Interventions can target various aspects of care. We can implement hand hygiene campaigns to emphasize this simple yet effective practice. We can promote the use of personal protective equipment or PPE. We can also standardize protocols for catheter insertion and maintenance. Proper central line care can reduce the risk of CLABSI.